right. Hey, everybody. and welcome to the Higher Estate, where we talk about all things related to cannabis and we bridge the gap, as usual, between the medical world and the lifestyle world. Today, I have some awesome guests. Before I even talk about that, I do want to say something that's really cool. Janelle and I are going to be starting the Higher Estate Morning Edition. So we're going to be coming on 7 to 8 every morning, giving you your daily dose of, oh, that's cool. Your daily dose. I like that. Your daily dose of, maybe we should call it the daily dose.
The daily hit.
Yeah. Not a bad idea. The daily hit. That's actually cool too. Okay, so you're gonna get your daily hit of cannabis and news related to cannabis, but we're also going to talk about wellness, health and wellness, all things related health and wellness, because as we know, cannabis we use as one modality in a whole bunch of different treatments when we talk about the wellness agenda. Cannabis is just one of those things when we talk about plant-based medicine as well. So we'll get into all those things, and hopefully you'll want to listen. Mom, I won't swear as much, I promise. Anyway, so today, Janelle, hi.
Hey everybody.
How's it going?
Not too bad. Hanging in there.
Yeah. How's your COVID quarantine?
You know what? As a mom to a 4-year-old, I'm going to tell everybody, check on your friends who are parents, who are home isolated with their kids. It's a tough time.
So it's funny. I was taking a shower. That's funny because who takes a shower when you're home all day? I was taking a shower and my daughter was downstairs, and I don't know if you can leave a 4-year-old. She's 5 in June. I was like, I probably shouldn't do this. So I ran out of the shower, grabbed my daughter, brought her upstairs, sat her down. And I mean, she was pretty cool because she was just watching whatever. And then I heard the dogs barking. I'm like, shit, is somebody going to steal her and come into my house? Anyway, I got all paranoid. Are you saying no, you can't leave? You shouldn't.
No, listen, I was on the couch one evening and I kid you not, my eyes just fluttered closed for like 30 seconds. And when I reopened them, I had hot pink Play-Doh smeared all over my white walls.
That is amazing. Amazing. All right. So we also have an amazing guest here today. His name is Dr. Nick Bottaro. He is out of Florida, and I met him at the Florida Medical Cannabis Conference. This is an amazing human. I was reading his bio. He's got more credentials next to his name than anybody I know. Whole bunch of doctorates and master's degrees. But anyways, as a human, he's an awesome dude. And he told me some really great stories about how he got into cannabis. And we're going to talk to him about what the state of affairs is in Florida. We know where we are in Canada, and we'll talk about a little bit. Hopefully we'll get into talking about what's happened now during the COVID or the SARS-CoV-2 pandemic, and how it relates to cannabis and what he's going to do, because he's also a medical director for a cannabis company out in Florida. So, Nick, hey.
Hey, thanks for having me. It's fun to be here. And yeah, we had such a good time at that conference, and it was so awesome to meet you and to continue that relationship too. Because you meet so many people at these conferences, and you're like, we'll keep in touch and shit like that. But how many do you actually do? And then it's just been awesome that, what has it been, like 3-4 months now that we've been talking and just keeping this relationship going. So I love it. So thanks for having me on.
Well, you're doing some really cool shit too, like, some undercover research, which is pretty cool. I'd love to know what you're doing when it comes to cannabis. I'd love to know what's happening with even ophthalmology. You're doing a whole bunch of stuff. So I want to hear about everything that you're doing.
Yeah, for sure.
Because that'll be pretty cool. And people want to know what's happening in the U.S. because, we hear so much about Canada, and here in Canada, we hear so much about Canada. And, the cannabis was taken off the essential services list. And so all of our dispensaries were shut down.
Really?
Yeah, every one of them. Not like you guys. You guys, it's still on the essentials list, right? Am I right?
Yeah, in fact, that was actually a huge thing that happened, is that it's always kind of been this gray area of, are we essential service or not? And now, COVID definitely pushed us. And thankfully, in the United States, it's kind of a state by state thing. But every state has absolutely recognized cannabis as an essential medicine, and we need to do everything in our powers to allow our patients to continue, and customers in our adult use market to continue using this medicine.
So that's pretty cool, because it was taken off of ours. They are allowing some things like they did reopen to curbside, but I mean, still, it was taken off the list just as quick as it was put on. So I'd love to chat with you about all those things. But first, we're going to do our little COVID corner update. Once again, I just want to give everybody like a little reference. What's the difference between COVID and SARS-CoV-2? SARS-CoV-2 is the actual virus, and then the symptoms that it causes is COVID, sort of like HIV is to AIDS. Same idea. And that's the way to look at it. And so we're still in the same place as we were. We are spiking a little bit. Actually, I'm going to give you some Canadian statistics right now. I think we have some stats up there with our little, where's everybody heading? So if you look at the little graph, you could see where we are today. That's the beginning of April. We were pretty low throughout March, and it was only in the last couple of days actually that we started spiking up. It was bound to happen. Are we overwhelmed? Not yet. I could talk about my own hospitals here. We're still fighting the good fight. We still have beds. We still have respirators. We're still doing a pretty good job of being able to care for people. And one of the major reasons we're able to do that is because people are physically distancing here. What's happening in the States? I don't know. Fuck. You guys are still doing booty shots, and I don't know what's happening over there. But
I don't think anybody knows what's happening in the States, to be honest. But
we don't really, I mean, the truth is we're all confused because we just don't know. We don't have it's something that's so new to us. We just don't have all the details. Like it's a new virus. We haven't seen this before. We know that it's come from an animal. Likely the host was a bat. Who knows? But we've seen zoonotic transmissions before. Most of the viruses we know today are pretty much from animals and transferred to humans. So that shit we know happens. Like we have the swine flu, bird flu. Fuck, now we have COVID flu. Shit.
It's the bat flu.
It's the bat flu. It's unfortunate. Nobody really knows what's happening. But what we do know is that physical distancing has worked. And even last week when I came on, I said we pushed week 1 till next week. So we're at week 1 now. We're still able to. We're still holding tight. What I can say is that we're up to. You guys are over what? How many hundreds of thousands people in the U.S. have this virus now? Somewhere around.
Yeah, I think today we just got over 400.
Yeah, you went over 400. We're at like 20,000.
Yeah.
So it's a big difference. We're at like 20,000 and like 500 deaths and
420 deaths confirmed. 420,000 confirmed as of right now in the U.S. Close to 15,000 deaths. And that's just of the numbers we're counting. That doesn't include, all the people that haven't been tested, that are sick and things like that. So the one thing that I've seen, dealing with this now for the past month or more in the U.S. is that, we go based off the knowledge that we had, the numbers that we have, but they're not very accurate. Even last week, they were saying our peak here in the States would be May 1st or around that time. They just moved that up 2 weeks to the third week of April. Here in Florida, same kind of thing. We were looking at beginning of May peaking, and now we're looking at early next week peaking. So many variables that you just cannot calculate. So many unknowns.
Yeah, and we have no time to do any of the studies. And everybody's talking about, we got to do this study and that study. I think we have time to treat people and try to help them. You know what I mean? And it's so tough because where, in the lack, when you don't have evidence, you have to go on your best judgment. And we're having all these conversations right now in hospitals as to, who are we going to, How are we going to intubate these people? Who are we going to decide gets these ventilators? All this kind of stuff. Hopefully we'll never have to come to that point here, because, you know, physical distancing is working. And, you know, I actually appreciate our premier. I know it sounds crazy, but I appreciate him for being super honest from the beginning, saying this is going to fucking suck. And unless you guys listen, there's going to be a lot of shit that goes down. So listen. He literally, that's basically what he said. It was just like, there was no, oh, this isn't so bad, guys. It was none of that. It was, this is bad. If you listen, dog die. Like at some point, like, you know, I appreciate the candor. Anyway, okay. So a lot of questions have come down, you know, I've been asked is what we can expect for the future, right? So let's say COVID ends. What happens? Or what's the natural progression of most viruses? And is COVID going to take on that natural progression? So there was a group that actually a YouTube that I watched out of University of California, San Diego, has they put out a really awesome lecture series done by a couple of docs here. This is what it is, USC TV. They did a really good basic science introduction to this whole virus. And one of the things, a couple of things they talked about is what are the variables? You know, we often talk, we're all talking quite a bit about how does this thing transmit? How many people get infected by it? What happens to this? What happens to the people who do get infected? And when we talk about transmission, I've talked about the R naught before. That's that big R that you see that usually has a 0 next to it. That number, that letter R, is how this thing reproduces. You always want to keep it under 1. And whenever you have something less than 1, that means it's not going to last very long. It's going to go away. Otherwise, it's going to increase exponentially. And so the R naught, or the reproducibility of COVID or of SARS-CoV-2 that causes the COVID the COVID symptoms is 2.5. So it's actually quite high. Now, that's 2.5 if we did absolutely fuck all. If we did nothing with our lives, lived our lives as we were supposed to, done nothing, gone to work, didn't socially isolate, didn't physically isolate, didn't do anything, the R naught, or the reproducibility of it, is 2.5. So for every person that gets infected, 2.5 other people are going to get infected, and they're going to infect 2, and then poof, you have the whole world that's infected. You know, which brings me to something else that's crazy. Okay, fuck it. I'll finish this point first. I never really finished my points. Okay, so things that we can do to change the reproducibility of it, or is what we're already doing. And that's wear a mask. That's physically distancing. That's wearing gloves. That's doing the things that we can do to get in the way of its reproductive ability, right? So those are things we're doing well. So that minimizes and decreases the reproducibility. Sorry. Okay, I have to say it. I got to get shit off my brain when I talk. By the way, I have a swear jar today, but I have no money for it. This swear jar was made like 2 years ago when I started podcasting, and well, I'm moving out. It's a sad day for me today because I'm closing my clinic in Hamilton, so there's nothing like really left.
A much larger jar.
Yeah.
I've had guys come in and drop $20 bills, $100 bills. They're like, I know what's going to happen here today. All right. So the reproducibility, we can change that. And the way we change it is by physically distancing. So guys, keep up the good work. One of the other ways we can change it, and this is going to come to all those anti-vaxxers, and I'm going to swear a fuck ton because, we have one virus that we don't have a damn vaccine for. And look what it's done. In 3 months, it's infected more than 1 million people worldwide. We've had over how many hundreds of thousands of deaths? Over 100,000 deaths worldwide. And this is in 3 months. All right. That's from the lack of one vaccine. So imagine we weren't vaccinating on the other things. You know what I mean? And people come to me. I've had this argument on Twitter, like, oh, how many times do we have measles isn't going to kill you. All right, well, COVID doesn't kill 80% of the people that get it, so, but yet y'all afraid of it and staying home. So like there's something to be said for that. So we definitely, let's bring up that next slide that talks about the immunity, what we can expect from this. So, most of our different the progression of most viruses into the future, either at one point we either have vaccines for them, right? Or we grow immune to them and we develop antibodies to them. And for the most part, right now, we don't have the antibodies. So can you technically get reinfected? Well, the question is, viruses are pretty cool because they usually die down every summer, but they figure out a way to change themselves and morph themselves. I'll tell you, we're dealing with over 9,000 variations of this COVID virus already. All right, I know it sounds crazy, but that's what happens. It infects one person, it changes a little, and it goes into a bunch of others. So it is it's not that it's smart. It follows its genetic code, and it has the ability to reinfect you. That being said, like you can get the flu every year. That being said, over time, most viruses, pretty much all viruses, either we come up with a vaccination or in time you develop immunity through antibodies. So that is likely the progression of what's going to happen here. It probably will stick around and it will mutate and it will change again, but over time we are going to develop some sort of immunity like we have with every other virus that you can think of. You will have a common flu, that those things still stick around, but one of the good things, I guess, what we can say as, just to finish up the COVID corner, is that COVID doesn't kill many people. I know it seems like it does right now, but when we talk about things like swine flu, or we talk about bird flu, or you talk about MERS, Mediterranean fever, whatever, you're looking upwards of 40% mortality. If you look at SARS-CoV-1, its mortality was really high, but its transmission was a lot lower. So now we're dealing with a high transmission rate, but a lot lower death. That being said, relative per capita, if you have, it's like cannabis, people that use cannabis, you know what I mean? You got 40% of the population. You're bound to have a bunch of people in there that have some sort of, even though the rate of abuse is low, it may look greater just because you got more people using it. So same kind of picture here. You may look like there's a lot more people dying, but it's still around 4 to 6% versus 10 to 40%. So I think on the positive note of this whole thing, if we have the ability to change its reproducibility and how many times it reproduces and how it does that, which we have been doing, we can affect that because we're fucking awesome. We can do that by staying inside or not meeting in large groups and doing all those things we're doing. And in the future, develop a vaccine that is going to save our lives or develop immunity over time from those who do recover from it. Then we have the ability to beat this thing. And clearly we're going to do that. Okay, that's all I have to say about COVID Corner. Boop. Drop the mic. Am I done? No, we're still going. Nick, do you have anything else to add to that COVID thing?
Yeah, I think everything you said was dead on. The one thing, a couple things that I was thinking of is, number one is one thing I've been getting a lot of feedback on is like, okay, it's this bad now, so now what do we do? It's getting worse. Now what do we do? And what I'm constantly having to remind people is a lot of the things that have been put in place by different departments of health or whatever it is, from the beginning addressed these more severe things of what to do personally. What can you do? So the social distancing, the hygiene, the hand washing, all these things, feel like, well, now what do we do? It's so much worse now. It's still the same steps to be able to mitigate and, as many people have been calling, flatten the curve. It's still the same steps. So if you're doing those things, as a lot of people have, and I don't know how it is up there, but in the United States, it's state by state, New England, New York, Connecticut, those areas hit hardest in the United States. They're on complete lockdown. So you go out on the road and there's no one on the roads. Florida.
When you say complete lockdown, like their businesses are closed or they're not allowed to leave their homes?
Yeah, all non-essentials. And then, so then the question is, well, what's a non-essential service? So And then that again is state led. So like New York and Connecticut, they really were strict on what essential services were. So the great majority of people are not working, businesses and jobs are closed. And it's really just the healthcare workers and grocery stores and things like that, the absolute essentials. The flip side of that is like, say here in Florida, yeah, we're stay-at-home orders are in place, but they just added like 20 different essential services, including like just things that are not essential services. So you'd see like massage therapy is on there. I'm sorry, but in a pandemic era, you can go a couple weeks without your massages. So it's really a state by state, and even in some cases county by county thing, and how they're handling it here in the United States. And regardless, so like in Florida, on my way to work, I'm an essential service. I in multiple areas. So, but I am still seeing very close to the same amount of traffic in the morning. And you're like, wait a second, what's going on here? Even friends that I have in New York, you get that just invincibility complex where it's like Prohibition era back in the 20s, where now in New York have these speakeasies that are popping up where people are gathering, and there are these underground bars and underground clubs that are still allowing these things to happen. So,
Wow.
yeah.
No.
Yeah, I got a lot of friends in New York, and they're just like, yeah, as crazy as it seems, like,
oh my God,
people will always find a way to do what they want. And so it's this whole balancing act of, what extremes do you go to keep people safe? But then the flip side is, what extremes, if we take those, how is that going to hurt us as a nation, or our economies, our businesses? We had a couple of my companies, we had just this past week alone, combined in 3 companies that I work in, we had close to 200 layoffs. So it's just crazy how it's hurting our economy, and it's also hurting our people. And the one last thing I'll add about this too is, and to kind of work off of what you were saying about how, this is our initial impact from a brand new virus that we know nothing about. This will come back. We will have this, and some models show peaking again in November, that we're going to have a second wave come in November. And I believe that too. But the thing is in November, we're going to have a lot better idea of how to treat this, better ways to treat it. We're already changing treatment plans now, where the intensivists are now looking at this to treat it as an ARDS, or like basically a lung failure case. And it's much more of a hypoxia case, and the hypoxia is not just because of lung dysfunction. It's actually, they're finding, because of blood dysfunction.
Yeah, there's a hemoglobinopathy
treatment thing happening now, where they're looking at blood transfusion as a potential treatment. So more and more of these things are coming out. And as you said earlier, none of this is tested. None of these are double-blind study. We have the science, but the science isn't tested or proven. So we as physicians and as a whole healthcare unit, a team, are really having to dig deep into that art of medicine, of saying, okay, let's think outside of the box here. Let's try these different things. And so in subsequent infections, whether or not it mutates or comes back or whatever, we're going to be much better prepared to handle this. As now, if you have symptoms of the flu, what do? You go get Tamiflu. Right. I'm sure you guys have that up there. But yeah. So does Tamiflu help? Great. Not really. It lessens the course by a day or two, but it's something. Could you see something like a potential for like a COVID Tamiflu type scenario? Yeah, absolutely. So, even there are anti-vaxxers like, ugh, but, like, fuck.
Right, like what? Like, there's nothing to say to them. Like, honestly, now they're sitting at home too.
And it's like, I can't wait till my kids grow up and their generation is like anti-vaxxers, and then I'm going to be the one sitting there like, yeah, you don't remember the hell that this put the world through, because now you get your anti-vaxxers saying, oh, well, polio. It's like, dude, polio was fucking bad.
Right. You don't want I had an anti-vaxxer tell me that polio wasn't killing anybody. and polio's not so bad. I'm like, because you didn't fucking live through it. So now you're living through one thing that has devastated the world in 3 months.
3 months.
3 months. It's crazy. Actually, I have that one other slide now that I was thinking about it. The what does the future hold slide, like the what's the likelihood of this coming back slide. And there's a couple things on that were, first of all, we are the cause of this entire thing. Every flu that we see, we've pretty much caused, specifically because there's zoonotic transmission that causes these things. They wouldn't have come to us if we didn't come to them. And it's interesting that when we look at it, we're likely going to see a lot more of these things because of all of these reasons. These slides were great, and if you have a chance to listen to that webinar that was given at University, mine says awesome. Okay, I gotta see squirrel. Derek, you can't do that to me. I don't even know what the hell I was talking about. Oh yeah. So we pretty much caused most of this stuff. And and I keep thinking about, I'm a meat eater. I like meat, but it's a problem. Like, that's how we get these diseases, by eating meat. If we weren't eating meat, we wouldn't have, and we weren't encroaching. So that's probably the word, on the environment that they live in, we wouldn't have this problem. We can live symbiotically together, but when we start trying to dominate another species, the species eventually says, go fuck yourself. Because,
well, yeah, you know how AIDS started.
Right. From chimpanzees. Like,
well,
not
sex with monkeys.
Right. Like, it's not normal. It's not normal.
Right.
But these are things that we as humans create. And so at the end of the day, we are the master consumers instead of the master. I think the world will change a little bit. I think when we get through this, I don't think the world in the last 200 years, has seen something quite like this. Maybe 100 years has seen something like this. Anywhere from our parents' generations all the way down my grandparents' generations, they've never seen something quite like this. Not in a first world country. And I think the world is going to come down to being a little bit more mindful. I don't know, Janelle, what do you think?
I mean, I definitely, I've had this conversation with family members of mine, and I think that this is going to be the catalyst for a lot of changes as far as how we deal with healthcare, how we deal with the economy. There's going to be so many changes. I was even saying, when you look at the economy, even from a freelance perspective, a lot of freelancers are now in the position where they're like, oh my gosh, I'm out of work. I don't have any sort of anything to fall back on because I don't qualify for a lot of these government subsidies and things like that are happening. So I think that's going to create a change in the gig economy. I think as far as healthcare goes, it's going to make a massive change because now we're going to look at things a lot closely. And I think a lot of people are going to start taking their health a lot more seriously, what we put into our bodies, or even right down to our personal space. Because when this is done, that 6 feet of space, I don't know if that's going to be done with it. I think a lot of people are going to respect personal space. Somebody gets close to you, you're going to be like, whoa, back up. You're not going to want that anymore.
That, that's a good point. I'm actually, I have, my wife and I have, or specifically my wife has the spin studio, and we spin in a box. Now, the truth is everybody's super healthy in there. And, I think you just have to take precautions. I think eventually we'll get back. We're human. So we need touch and feel. We need that social experiment. That's just what we need. And somehow we're going to get back to that, but it's going to be a long time.
Yeah.
Anyway, I think we I don't know. Well, that brings me to the cannabis space, because right now we're in a whole heap of the cannabis space is in a whole heap of shit. And when we get to the news, eventually we'll talk about it. But let's get to Nick here a little bit, because you're an ophthalmologist.
Yeah.
How do you go from eyes to cannabis? How does
They happen both very independently. So a little bit about my backstory. So I actually, growing up, was not a big fan of cannabis, using it. Tried it just like everybody else. Tried it, and I think actually first time I tried it was 7th grade. I was kind of a bad little kid, but tried it, didn't like it much. Tried it a couple times in high school, didn't like it much personally. I knew how to sell it, that was for sure, in high school, but didn't like it. College, same thing. I was not a big user. And in hindsight now, I really wish I knew how to use it appropriately. I think it could have helped me so much in my youth. But anyway, so didn't pay much attention to it until you fast forward a bunch. And I'm in my 3rd year of medical school. And I get a call from my mom. And so I say, hey, Mom, what's going on? My mom and I, very, very, very close. Amazing mom. So I get a call from her, and she's like, hey, just want to kind of let you know what's going on. And she's a nurse, so she knows a little bit about kind of what was going on too. But she goes, I made an appointment with the doctor. I have painless jaundice. And so, and I know, and anybody in the medical field knows, a painless jaundice is a trigger word. It's like your stomach drops. It's like shit.
Can you just explain what jaundice is for people?
Yeah, sorry. So jaundice is like yellowing of the skin. It's like a discoloration of the skin. Usually shows up in the eyes, usually first, actually. But so basically, it's because of a liver dysfunction. When your liver is not working well, you get a buildup of these toxins that actually turn your skin yellow. And when it's painless, it actually kind of directs you into a certain diagnosis. So anybody that kind of hears in the medical field like painless jaundice, you're immediately thinking like, oh shit.
Yeah.
So I heard that. I'm in med school. I had literally just finished the week before my surgery rotations where I performed a Whipple. I was first assist on a Whipple, which we don't have to explain, but it's just a big surgery for this problem. And so long story short, ended up my mom was diagnosed with pancreatic cancer. Pancreatic cancer is a death sentence. It's a 5% survival rate at about a year. So I knew, and literally the week before my mom called me, I had performed a Whipple procedure, which is this major surgery for pancreatic cancer people to try and help them survive. But it's a grueling surgery, 8-hour-long abdominal surgery. Anyway, so I knew what it was, and I just collapsed inside. Fast forward, so I'm really directing my mom's care. She's at the best institutes, really arguably in the world. She's at top-notch hospitals in New York City and Boston, these experts on pancreatic cancer. And she's about 6 months into treatment. She's not doing very well. She's in a lot of pain, and she's all hopped up on opiates. She's sleeping and passed out 20 hours a day, and the 4 hours a day she's awake, she's out of it and in severe pain. So, I'm a naive medical student at this point. I'm learning as much as I can, as fast as I can about this cancer and treatments and everything. And so I figured, very appropriate, let's ask. If anybody knows about medical cannabis, it's these top experts in the world in cancer research. They got to know about it, right?
Yeah.
So I go,
yeah, right.
Yeah, right.
Honestly.
So I'm like, all right, it's an acceptable question. Hey, docs, my mom's in terrible pain. You're giving her 8 milligrams of Dilaudid, Q4, 6 hours, like just stupid amounts. I said, what do you think? Let's try cannabis. And they basically laughed me out of the room.
Wow.
And, at that point, my whole world was in chaos. So I was just like, all right, probably a dumb idea, Nick. But then I was like, damn, like they're not even open to this. So I kind of made a promise to myself at that point, like if there's ever an opportunity in my future, I don't know how it's going to present itself, but if there's ever an opportunity in my future, I'm going to jump on it because I don't want other people's families to meet that type of closed-mindedness.
Wow.
Especially in a situation where there's no cure. We're not going to cure her. It's just about quality of life at this point.
Yeah.
And to have closed-mindedness as a physician, when you're even especially end-of-life care, like, what are you doing? It's just pride at that point getting in the way. I said to myself, I'm going to help if I can.
I think most of medicine is like that. I've been doing it for a decade now. It's so amazing when I hear somebody like another physician say that, like what you just said, because I mean that's really why we are in medicine. We have to help people, and I have this idea that, you know, do no harm and then do everything else you can.
Yeah.
That was my that's like the motto that I've lived by for a decade. And you can't tell physicians, the mainstream physician just doesn't like to hear it. I deal with it still. It's still crazy, but that's amazing that anyway, go on. Fuck, that was
Yeah, so no, you're good. So basically I made that promise to myself. You know, my mom unfortunately passed away, so it was about 4 years ago now, and
so she didn't get.
She did not get cannabis. No.
Wow.
She, in fact, she was such an amazing woman, very spiritual woman. You know, went to church every day and just like, just incredible woman. But she said, I was like, Mom, let me go down the road, talk to one of my buddies, and like, let's just, you know, at least try it. And she said, Nick, you know, if you can't do it the right way, I don't want to do it.
Wow.
And you know, it really broke my heart because those last 3 months of my mom's life, when she was really just, she might as well have died months prior because there was nothing there. There's a little bit there, but you know, my point is the quality of life that could have been there if she wasn't on narcotics. We could have my brother, you know, I have 2 older brothers. Just my mom and her 3 sons could have really had a lot better memories those last couple months of her life. She could have had a better experience at end of life care. It was just super tragic, and it didn't need to happen because it wasn't like a legal thing. It was a pride thing on the physician's part, because it was legal in the state.
It's because the physician knows less than the person requesting it, and they get so fucking defensive.
Unwilling to even. Now, it's funny actually because Harvard is now on the forefront of some of cannabis research today.
They all jumped on the bandwagon when the money started rolling in.
Especially for, I don't know if you know the name. I think we've talked about him before, Dr. Henry Lowe.
Yeah, of course.
He's out of Jamaica, amazing guy, but he actually has the first patent a U.S. patent on a flavonoid that Harvard is now using specifically for pancreatic cancer treatments. So I'm just like, this is bullshit. But
unless they're doing it, they don't want to listen to anybody else, though. Right. Even the big universities, I'll just quickly, I started, I've been doing this for a decade now. I was probably, this clinic that's now closing was the first long-term clinic in Canada, and maybe in North America for its length of time and its sole purpose. And when McMaster decided they were going to start a cannabis research group, and they called me up and said, "Hey, do you know anybody that can join our research group?" And I said, "I don't understand. You're talking to the person like I'm right here." "Oh, no, not you. We need other people, not you." And I'm like, I don't. That doesn't really make much sense to me. And it's because unless they're doing it themselves, they feel like their lives are threatened. And medicine isn't a collaboration. It's a collaboration of chiefs, right? It's a collaboration of I'm the best and I'm the best in my own field instead of we're all in the same field together. And those guys are anybody that's in a different field or has a different specialty, even within the same field, they'll always collaborate together. Because they're all the best in their own thing. But as soon as somebody has more knowledge than another physician who's in the same field doing the same thing, all the defenses are up and shit just goes the wrong way.
Yeah, exactly.
Sorry.
No, you're good. They're good points. So basically what happened was, I started my residency in ophthalmology. I've always been passionate about ophthalmology. I just love it. It just fit for my personality and what I was looking for. So I love what I do in ophthalmology. But then all of a sudden I'm in Florida, and Florida now becomes a medical state in 2016, actually. They started more so in 2017. But so I was like, shoot, let's see what this is about. And so I got certified for it. And to be honest with you, I knew nothing about cannabis medicine or how it worked, other than the little bit of research I did when my mom was sick. But I didn't really know much about it. I wanted to jump in, so I did. And I was like, I'll figure it out as I go. Within a week of seeing patients, I was blown away by everything I was seeing. Just there's really no way to capture it as a physician. Your whole goal as a physician is to help people in a natural, healthy way and give them back a quality of life, no matter what it is, whatever sickness, a broken bone or whatever. The goal is get them back to a quality of life, and if not even a better quality of life than they met you with. And cannabis was like, wow. Oh my gosh, how is this possible? How is this actually achieving that goal in a way that I have not seen, and I'm sure you would agree, in any other discipline of medicine? I've not seen it. There's no other medicine that I can say comes close to what cannabis medicine does for the amount of people and the amount of ailments that it can do it for. So I was like, shit, I gotta know this, because for me to actually believe in something, I have to know why and how. And that's, you know, at the beginning you mentioned all like the letters. I think I have more letters at this point than that spell my name, but
you do.
But the point wasn't.
By the way, he's got a doctor of osteopathy. He's which is fucking cool. He's got a master's in administration and master's in public health, a master's in blah, blah, blah.
Yeah. So, but none of that was ever actually. I have zero care about letters after my name.
Of course, I get it, but you know what it does? It legitimizes what you do. It also means you search for knowledge, and that's so important.
And that's the whole thing: search for knowledge. So, you know, I was working in the hospitals, and I said, I hate how hospitals are working in the United States. I hate how the administration is in charge, and doctors are pawns. So I said, I want to figure out what the hell is on that side. So I went and got my master's in healthcare administration. Wow. And so then I was like, okay, cool. Now I understand that side. I understand my side. And then I was able to start crossing that bridge and connecting those dots. Right. Master's in public health was more of like, that came about, actually, that was a freebie where somebody was like, hey, you want to do this master's program? It was my medical school that was offering it. And they were like, we'll let you do it. And I was like, okay.
Really?
Yeah, it was sweet. Amazing. So that was just like thrown in my lap.
Hey, is it true that they passed every medical student in New York? Did you hear that?
So it's not every student, but it's a lot of them. And it's something I actually very strongly disagree with.
Okay, what happened? Tell me what happened.
So it started with Cornell University. Cornell University graduated all of their fourth-year medical students prior to graduation date with the sole purpose of getting them into a hospital and getting them part of the workforce. Ooh. Now, you and I both know, you don't know shit.
Nothing.
You don't know a damn thing. Even like, okay, you learn a little bit during clinical rotations your fourth year, but you don't know a damn thing. You're a doctor, but you are not a doctor.
Right, yeah.
And, you know, there's a reason why the death rate, this is sad to say, but the death rate is exponentially higher in the months of July and August.
Right. That's so true. You don't want to be a patient.
That's because you do not be a patient in July and August.
Yeah.
So so all they did was fast track that.
The reason why, by the way, you don't is because that's when new doctors start working. When you finish medical school and you start residency, it's in the month of July.
Right. And so all they did was push that timeline ahead. God. And so now you have these completely inexperienced, naive, brand new physicians that, if they were anything like me, are going to be really gung-ho and not know their boundaries. Right. And now not only are we putting the patients' lives at a little bit more risk, but we're putting these brand new kids' lives at risk. And so my heart just breaks when I read about new interns and new residents that have died from COVID.
Yeah, we don't talk about that much, eh? We talk about physicians like staff doctors and nurses, but what about our residents are still in there?
You know, there was one day last week in New York that 3 residents died. 3 residents. Shit. These are people at the start of their lives, at their start of their careers that could potentially help tens of thousands of people in their lifetime. And because of this, I feel like it was a poorly thought out plan to put them on the front line. what are we doing to our people? It's, it reminds me very much to a military draft, back in the day when we were throwing 18-year-old kids out in World War II and Vietnam. Like, what the hell are we doing? So I was very much against that. And so Cornell did it, and then a bunch of the other schools did it. And it's just, it's really sad when, I have, and especially because a lot of these people.
Except if you're the med student who doesn't have to write a board exam. I'm like, shit, wish they did that when I was going through.
Well, I'll be honest. So I had a big board exam coming up for ophthalmology, and that got.
There you go.
Yeah.
Winning.
Yeah, we have to read the boards. Yeah. So, anyways, so.
All right. So back to cannabis.
Yeah. So for me, I saw this in the first week, and I was just like, it was eye-opening, and I was like, shit, I got to learn everything I can about this. So I did. I dove into the research, everything I could get my hands on, quality research, and sought out the professionals, sought out the experts across the world. And I taught myself everything I could about this medicine with the sole purpose of being able to help patients better.
Wow.
What I found, and I think you would agree, is by knowing this medicine and the ins and outs of every aspect of this medicine that we can at this point, the success I had with my patients was exponentially higher than the physicians that were doing this that didn't care about how it worked or why it worked, how to do it.
They were just looking. Yeah, that's a great point. There's two types of physicians in this cannabis industry, and those that see their patients and care about them, and those that are just there to make a buck and try to figure out, like just the script mill guys. I totally agree. The script mill guys don't really care, but yet somehow they're, and they're the ones that are actually super busy. And that's because it's so easy to get an appointment with them. They want to see you in 5 minutes. They don't take the time, and the people that go to them just don't care either.
Right.
So I totally agree with you. Yeah.
So, and unfortunately, I don't know if, I'm sure it's the same up there, but the percentage of physicians that care is a very small percentage in this industry, which is, it's been tough. It's been tough over the years to really get out the message and educate. That's a huge part of what I do, is just educating other physicians on how to do what they're doing better.
So now you're working with a company.
So yeah, so before that, so I started doing it. I did it for, I saw patients nights and weekends, cause I was still doing ophthalmology during the day. And then nights and weekends, I was doing cannabis. It was killing me, but I loved it. So I was like, okay, this is meaningful for me. It's fulfilling. So I did that for 2 years. I saw about 7,000 patients. When I ended, it was 5,000. And then over the last 2 years, it's been an additional 2. But so 5,000 patients in 2 years was I never expected that. I never expected to grow as fast as I did. But when you put out good quality education in medicine, it's crazy how attractive that is. So without even planning, I became kind of a leader here in Florida. And then, but the hours were killing me. I'm a single dad. I got 3 little kids. So I was like, shit, like I got to figure this out better. And along came one of the cannabis companies here in Florida, and we're in 7 other states and 3 other countries. But they've
Did you mention the name or no?
Formerly, they were known as Surterra Wellness. They're now called Parallel.
Yeah.
More commonly known as Surterra Wellness. And so Surterra approached me last year and said, hey, listen, like we see what you've done in the community. We see, what you have to offer, and we want to bring you on board. Unfortunately, in Florida, I can't see patients and also work for a dispensary. And so it was a tough decision.
What do you mean? It's too much of a conflict?
Yeah, exactly. So we have, it falls kind of under what's called the Stark Law. So the Stark Law is that you can't have invested interests in the place that you are directing your patients to. Right. So for instance, I can't own the drug that I'm also recommending my patient to buy the drug. So definitely conflict of interest doing both. And so I had to unfortunately make that decision to give up seeing patients, but I did it with the thought that came true, thankfully, that, okay, in 2 years, I was able to touch 5,000 patients. In less than a year with this company, I've been able to effectively help actually millions of patients because of how now I'm involved in orchestrating and designing legislation, designing products, And just that being able to affect at a higher level, that trickle down effect is now hitting tens of thousands of patients. So that was kind of my justification. I missed the one-on-one patients. I still do it here and there, but in an unofficial kind of consultant form now.
Right, of course.
So now I work for this big company, and it's been incredible to be able to really influence, their movements, to make sure that they stay with a very medicine mindset. What's something I found in this industry is that once it goes to adult use, you lose a lot of the medical utility. And, why do I have to see a doctor if I can just go to the store and buy it? Well, because the doctor's going to tell you what to buy, how to buy it, what to use, what's going to be best for your diagnosis and your experience level, so on and so forth.
I agree. What's happened with since legalization? You guys have use as well, or is it medical use?
In Florida, it's just medical, but like our biggest stores are actually in Massachusetts. So Massachusetts has adult use and medical.
And so what do you find, what have you guys found in the U.S. since legalization? Are people still going to medical doctors for it, or are they mostly focusing on going to the dispensary but looking to somebody for education?
Yeah, and I looked at these numbers probably about 2-3 years ago now, and at that time, I would gather it's much different now. But at that time, a state that went from purely medical to medical and adult use lost about 20 to 30%.
Yeah.
And so I actually expected that to be higher. I think that if I looked at those numbers today, I think it'd be even higher. But it's definitely it's a problem.
I think it's probably about upwards almost 50% now.
Yeah.
The 50% of the patient that we had back then, the truth is our population our demographics have totally shifted. The average age now, initially when I was doing this, the average age was probably 40-year-old female. Now I'm looking at the average age 65-year-old female. Mm-hmm. And 60 and over aren't going to the lifestyle market. They're coming to a physician, and they always want to be seen by a physician. Mm-hmm. Here in Canada, they all believe healthcare is free. So, it's always been, it's not free, by the way. We pay for it in our taxes, and we pay 52% income tax. Okay. Like pretty crazy. In whatever tax bracket, upwards of 52%. And so what ends up happening is the demographic being totally shifted. Those people want to see a doctor, and they want to see you face to face. So that's like the focus right now, is more on the laundry list of medications that they've literally just had a fucking enough of using, right? Like you got people that come in on 12 different medications. And what I absolutely love about this is about cannabinoid medicine is that we're so used to, and this is one of the defense mechanisms of the physician. We're so used to having 9 drugs to treat one disease. But now we have one drug that treats 9 diseases. And so I see somebody come in with a laundry list, and they leave on 2 medications, 3 medications, and that is like the satisfaction. And that's when I'm like, fucking mic drop right there. And I like, you know what I mean? And yeah, like it's just awesome seeing it. 13 medicines was my like highest that I've seen somebody come off of. And she goes around, talks about it all the time. And I think I spoke about her a little bit when I was in Miami there, or sorry, in Orlando, in Florida, or wherever we were, Orlando.
It's interesting because I actually, right before I finished kind of seeing patients officially, I sent out a survey. And I think you actually presented something like this too, but I sent out a survey to my 5,000 patients, and I got like a 95% response rate. So it just actually really powerful survey. And that was some of the big questions were, how many meds were you on before cannabis medicine? How many were you able to come off of? And it was something like 87% of those 5,000 patients, 87% lost up to 5 medications.
Wow.
And then it was something like 32% were between 5 and 10 medications. And then there was a very small outlier of like, it was like 2 or 3% of that total was 10 or more medications that they were off of. And it was just like, holy shit.
What
like,
were you
kidding me?
It's crazy. You were telling me about some of sleep's, how cannabis was helping sleep, and some of the sleep study kind of stuff that you've seen, you know.
Yeah.
Can we get into that quickly? I want to talk about that.
I know you love that stuff. Yeah. So.
And it's so important for patients to hear.
Yeah, absolutely.
And if you could talk about the different cannabinoids that you were finding and what parts of the sleep they were affecting. There's so much confusion around how cannabinoids help sleep, and and we were talking about REM, and it's not like you're really losing REM, you're just going through it quicker. Remember?
Yeah, exactly.
All the time now. And what cannabinoids do, just go through it. People will love this. People need to hear this shit.
Yeah, so I mean, obviously, when you talk about cannabis, like one of the main things, pain comes up, anxiety comes up, sleep comes up, hands down.
Always
so those were 3 areas that I wanted to focus my initial kind of research in. Once I learned everything I could about it, then I said, and I was seeing patients, and I was like, I want to come up with actual objective data, because that's what I believe in. Like anecdotal, yeah, I have a shit ton. I don't know if that's a New England term, but a shit ton is a lot.
Perfect.
We have a shit ton of anecdotal data.
Yeah.
But to my colleagues, it doesn't really mean anything. So it means a little something if they also have that anecdotal data. But if they don't have that experience, then my anecdotal data means nothing to them. They're like, okay, prove it.
Right.
And so I was like, okay, so sleep was a big thing. And I have access to a good friend of mine who's a pulmonologist, actually, who also runs a sleep center. And so we,
long doctor.
We had volunteers and that were using cannabis medicine. We started doing sleep studies on them. And the data was not only impressive, but it was consistent. And this is a big thing that we were worried about, was consistency of data. Because there's 100 different reasons why sleep is a problem. It could be PTSD, or it could be pain, or it could be, a million other things. So, but does the medicine work consistently no matter what the reason is? And we found that it actually does, which is incredible. So what did we look at? We looked at different forms, different routes of how to take in cannabis medicine. So whether it's inhalation or oral, even patches, things like that. We looked at different ratios. We looked at different cannabinoids and different actually terpene profiles. And what we found was a very specific, all of them worked. Let's get that out. So cannabis medicine works for sleep. But we found it's about 5 to 6 times more effective if the right cannabinoids and the right dosing is used. And so we found that it's a combination of THC, CBD, and CBN. CBG actually is incredible too. CBG is a second arm of this study that we're now working on. But initial reports on a combination of THC, CBG, and then also CBG, CBN. These are really, really good combinations, especially for very cannabis naive or very THC sensitive patients. A CBN, CBG combination has been shown to be, we're finding anyways in a small population, to be almost as effective as a THC product. So really good stuff.
Really?
There. But so basically so we found this kind of set ratio, and then the
what is this ratio?
What's that?
What is this ratio?
I'll
see it in the product.
Yeah, it's a fairly equal amounts of THC to CBN. And CBD in a little bit lower amounts. So you could call it, without giving you any proprietary stuff, you could call it close to a a 1:1 to 3 ratio.
THC, CBN,
CBD.
Okay.
And then terpene profile, actually, this was interesting, but it makes sense. Terpenes, we know, are so important to give our what I just say is the terpenes give you what the feel of the cannabis. So is it going to make me happy? Is it going to make me tired? Is it going to make me this and that? But what we know from terpene science is that the terpenes, especially when you inhale THC, the terpenes hit almost immediately. You get an effect from terpenes immediately, but they actually only last about 30 to 45 minutes. Whereas the cannabinoids will last with inhalation, an additional hour or two, depending on the person. So that's, if you ever get the question, I'm sure you have, of why do I, when I use a sativa, which is this terpene profile that, is labeled as a sativa. I hate that language, but
I don't use
it either. But very high limonene content, myrcene, things like that. But this profile, it's supposed to be, the point is, it's supposed to be activating. Why do I use an activating cannabis product, but then I always end up tired at the end of it? Well, 2 reasons. One is because that terpene profile is actually gone after about 45 minutes, where you're still having the effects of just pure cannabinoids. THC in and of itself at a small dose is activating, but it's a biphasic curve. So it has a curve like this, but then if you hit a peak dosage and then it comes down and has a different effect. So at the other end of that curve, it's actually a different effect. And that's where sedation, on this end of the curve, that's where sedation from THC comes from. Yeah. So in my opinion, you've overshot your dose at that point, but that's where unfortunately, most people end up.
Most people in the rec world want to be there. So they end up taking a whole bunch of THC or whatever it is. And
they just get sedated.
And they just get sedated after like 20 minutes.
Right. So exactly. So the terpenes are gone.
Yeah.
And now you're getting the high dosage effect of the THC.
Yeah.
So
the half-life is a little longer.
So coming back around is saying that
so back to sleep.
What we found with sleep was that the terpene profile wasn't nearly as important as we thought. Mm-hmm. I was expecting the terpene profile to be massively important for quality of sleep, and it actually wasn't. Even with giving this sativa type profile, that first 45 minutes, it became much more difficult to fall asleep. But how it affected their sleep cycles was still consistent regardless of the type of cannabis used. And that was really interesting because that was a little different than most studies I've read.
Yeah. So you're saying it didn't matter what the profile was. It was the ratios of what cannabinoids.
Exactly.
Uh-huh. And so what did you find? Like, what is it that, let's say somebody has trouble falling asleep, but okay, staying asleep, versus somebody who falls asleep well but can't stay asleep?
Yeah, so that has to do more so with the route. So the route of use, and this is what you do it too, is I, until the industry gets to the point of kind of advanced pharmaceuticals, it's as simple as you're kind of designing your own time release. So for my patients that have difficulty falling asleep, it's as simple as using an inhaled route, because it works within 5 minutes. It works for 2 to 3 hours. So you're in bed, lights are off, TV's off, because intentionality matters too. And I'm sure you know this. I know you know.
I always talk about that.
Yeah, intentionality matters. If you're up watching TV in your bed and you're smoking, you're going to be watching the same movie an hour later. And then you're going to be like, oh, why the hell am I watching a movie still? I was supposed to be asleep.
Right.
But if you had just closed your eyes, you would have been asleep that whole hour. So intentionality matters. But if you're trying to go to sleep, inhaling will put you to sleep 5 minutes. It was very rare for me to have a patient that would fall asleep or have difficulty falling asleep, but once asleep would get 6 to 8 hours. That's a rarer patient to me than the patient that just says, I have difficulty falling asleep and I can't stay asleep.
Right.
So typically inhalation for getting to sleep, but you do a time release, because when you want to go to bed, you inhale your cannabis medicine, and also take an appropriate dose of oral medicine. Reason being is because the inhaled is going to work right away, but the oral is going to kick in an hour or two. So when the inhaled is tapering off, the oral is then starting up, and now you're talking about 6 to 8 hours of a deep restful sleep.
Did it matter which cannabinoids you were using to stay asleep or fall asleep?
No.
Interesting.
No. So the ratios of the cannabinoids were consistent with just sleep in general. And I believe our theory here is because of how it interacts with the sleep cycles. And so I know that's what you wanted me to get to.
Yeah.
To the next point. We talk about different sleep cycles, and everybody knows REM sleep. So REM sleep is actually a half conscious sleep. So that's where all your dreams are happening, because you're actually half conscious. Your brain is awake even though you're sleeping. And so, but REM sleep is necessary. Everybody needs REM sleep. In fact, sleep studies or the sleep science is so cool, because if you miss out on your REM sleep at night, your body actually will force it during the day. And so daydreaming is actually, in many instances, a form of REM sleep. And there's other moments like that, or during the day where your brain kind of shuts off for a minute, or you zone out. It's actually, in many ways, we call it, I'm exhausted, I'm tired,
right.
I zoned out. It's
like
actually
my daily life.
Forcing a REM sleep.
Thought it was
because it missed it. So anyway, so you need REM sleep. And one of the concerns with cannabis medicine is that we knew from previous studies that it significantly shortens REM sleep. So what does this mean for long-term use?
Right.
Because loss of REM sleep actually can rear its head in a lot of psychiatric disorders.
Right.
And cause psychiatric disorders. So there's a concern here with the science of this. So what we found, though, was that yes, it shortens REM sleep. It extends by up to 20 to 30% your delta sleep. Now, delta sleep is where it's your deepest level of sleep, where all of your healing happens and where your rejuvenation happens. So that's where you get that's why you could take, a short power nap. You could take a 2-hour nap and just have phenomenal, or even 20 minutes, but that's a different reason. But while you don't need an 8-hour rest to really get a boost of energy, because that healing is coming in delta sleep only. So we're extending the amount of time of rejuvenating sleep. We're shortening the REM sleep. But because we're shortening the REM sleep, which is actually a decently long period of sleep, we're able to actually we're able to get an extra cycle of sleep in, or at least the REM part of it. We're actually able to get an extra REM cycle in to the same amount of time.
Now that to me is fucking awesome.
Yeah.
Because, I was always under the impression that, with PTSD and all this kind of, with everything, we're going to decrease your REM. We're going to get you, lower REM, and then you're going to be, so you don't dream and you don't get night terrors. You're just going to pass through it quicker. You're going to get more delta. You're still going to get deep sleep. You're just going to go through REM a lot quicker, but you're still going to get it, and you're going to get an extra cycle. I think that's phenomenal.
It's crazy because it's like, I told you I used to hate it, but I've been a daily cannabis user now for going on 5 years. And I honestly, I get about 4 to 5 hours of sleep a night. And I function great. My energy levels are great throughout the day. I'm not foggy at all during the day. So for me, just my work is a very high demand where, I'm working, and it's just because that's the amount of sleep I get, but it's not like an insomnia. It's just because that's what I allow myself to sleep. And it doesn't hurt me, because even in that 4 to 5 hours of sleep, I'm getting the same type of amount rejuvenation part that I would be in 6 to 8 hours of sleep. And it's just phenomenal.
Nick, it has been an absolute pleasure. You're a wealth of knowledge, and I'm right. See what I'm saying? Right. We could go forever. We're not done. We got news.
Looked at my phone. I was just like,
we got news because
I thought we just started.
We did just start because this is what happens when I start talking. When you start talking, this is like when we get into our zone, we could go forever, and it's just like it's like nothing ever happened. I want to continue the talk, but we got to get to some news that
Sure.
we're going to interrupt this broadcast to bring you the news by Janelle. But I think it's crazy. So first of all, I just want to summarize the sleep thing, because I think it's amazing, and this is what and it's how I explain it to people. Cannabis users potentially require less quantity of sleep in hours, because your sleep that you are getting is the quality of your sleep is better. And I think that's the take-home message from this. So cannabis can help with sleep. Just give me a number. How many patients do you think were put through that? More than your sleep study. The sleep, yeah.
We had on our first study, we had 40 patients. So, not a huge N. But
how many are you up to now?
So our second leg of the study is those 40 patients. It's crazy. People that want to do cannabis research are so committed. We had, I think, like a less than a 2% drop-off rate of patients. It's so awesome. They're dedication. So those same 40 came back for our second leg, and we added an additional 30 onto it. So, not massive. It's tough to do cannabis research right now.
Oh, yeah.
In the United States, because it's actually kind of illegal to do. Yeah. So we have to be very careful on how we do it and what we do. And of course. Really, it's more of just we're observing is really how it's classified, is we're observing people's habits, and that's how we can get away with it. But when these restrictions loosen up, I think, it's not just me. There's so many scientists and physicians doing kind of underground studies that as soon as this kind of, the fear of getting in trouble for it, you're going to see studies like this coming out that are then going to be peer reviewed. And that's when you see this in every hospital system and every physician's office.
When America gets federally legal on this thing, which may happen. I mean, we're in an economic crisis now, and cannabis revenue can probably save it. The world will change, because it's the U.S. Like, the opportunity is so huge. You guys have the ability to do so much over there. We do a whole bunch of studies here too, and we have the ability to do them. But I think the U.S. usually, the world follows what happens over there. So I'm super fucking excited, and I fully respect everything that you've done and that you are doing, and in such a short period of time. Remember, this only came legal there in 2016. We've been fighting this over here for 2 decades, and I've been doing it for about a decade. And starting from scratch. I mean, and it is a sad time for me. I already said that. The clinic I'm sitting in now at Synergy was probably it's definitely the first clinic in Ontario, the longest running clinic actively in Canada at this point in time. And it's closing because of COVID. There's no reason. We've moved everything virtually. I'm keeping one of the clinics in Burlington. So it's a little bittersweet for me, but the progression is happening, and I'm glad there's people there that are continuing the legacy and moving it forward and going to take it a lot fucking further than I ever did. And that's huge. And you're that guy. I listen to you talk, and it reminds me of it reminds me when I started. And I mean, I still have that same passion. It's so crazy that like you said, those who are working in cannabis and want to do cannabis research, and that we're just like, it's like gung ho, because we know that, and I firmly believe cannabinoid medicine will revolutionize the way we practice medicine. Anyway, we need to get to, let's get to the news. Janelle, what's going on?
All right. So we're kind of starting off on a little bit of a sad note. I don't know if you guys remember Charlotte, the young girl who the Web CBD was named after. She actually passed away yesterday.
That Charlotte passed away. I'm so sorry.
Yeah, it's a sad time for the cannabis community, because she was kind of really at the forefront of bringing the awareness of like using CBD for treating epilepsy. So for a lot of people in the cannabis community, this is kind of a sad moment, but on the bright side or the silver lining of it is through her advocacy, she was actually able to help so many people. So I think that's the kind of like the solace that we can take from the situation, that even though she's gone, she brought about so much change and so much good in the industry.
Epidiolex, I mean, basically is Charlotte's Web, and it's it just became federally legal in the United States too. It was taken off
And
of that.
descheduled, actually.
Descheduled, that's what I meant. It was descheduled, yeah.
She, you know, I don't know if I'm supposed to chime in on this wiki part, but no, and you know, I put out a message today to everybody that follows me, is that you really, if anybody that's ever used CBD or cannabis medicine really needs to just take whatever you do, whether it's prayer or good vibes or energy or just whatever it is, really needs to send it up to her and her family, because we would not be anywhere near where we are today without her influence and the impact that she's had, even in my own life, with my personally as a cannabis patient. Just incredible little girl, and unfortunately, she actually passed from the coronavirus.
Yeah.
Oh no shit.
Yeah.
Yeah. Complications from it.
Fuck. This fucking thing.
I know.
We need to beat this thing with a spatula, or my mom's cane. It needs a beat down.
Yeah, it does.
Can we go to some happy shit? Anything? No? Okay, what else you got?
So on an interesting note, I mean, the stock market in general is taking a hit right now, but in particular, cannabis stocks are taking a hit. And one particular stock that is having an extremely rough time is Aurora Cannabis, which is kind of ironic because when cannabis stocks really started surging, that was kind of the one that everybody was saying, like, you need to invest in. And it was really, really popular. But it has now lost 92% of its value. And it's sitting at 80 cents per share right now. And I mean, the way that it's trending is it's looking like it can fall to zero, because right now, Aurora Cannabis, their projected liabilities for the rest of the fiscal year is a lot higher than their actual cash flow. So
I think all of them are like that.
Yeah.
Like, there is not a cannabis LP right now in Canada I can think of who's cash flow positive at all. Like, and they were trading in the US too, right? Is that what's up?
Yeah,
I don't know. Bruce Linton said on BNN there the other night that at the end of this whole COVID thing, there's going to be 5 or 6 LPs left. Who the hell knows? It's a bloodbath right now. The bubble burst. Everybody's falling apart. Throw it all away. I don't fucking know.
It's crazy because when you think about even like a year and a half ago, like it's what everybody was jumping on. Got to get these stocks. And now everybody's just kind of sitting here like sadly, like, what did I do?
Yeah, well, I'm thinking like the same way. Like, what did I do? I think retail is going to bring everything back to life, but I mean, at least that's what I thought. Although right now, like this couldn't have hit at the worst time. Like, this COVID thing was just like a bomb in the middle of like the busiest intersection at the busiest time when everything was is again chaos again. So who knows what's going to happen?
I definitely don't think it's necessarily a bad thing that the bubble's bursting, though, because I think that the potential for this bubble was so massive, and it had we didn't know when it was going to pop. We just knew it was going to. Yeah. So I think that this may have popped the bubble before it really could have done a lot more damage than it could have.
Yeah, that's true. I mean, here in Canada, it was already like it was either feast or famine, It was like people either did really well or lost their shirt. And and I think it taught everybody a lesson, who was in it. And it's a good point. What else you got? Shit, this is all sadness.
Well, I mean, it's it's the era that we're in right now, which is unfortunate. So data published in the Journal of the American Medical Association actually stated that incidences of e-cigarette or vaping product use associated lung injury are primarily concentrated to jurisdictions where cannabis is still illegal. Honestly, for me, that's no surprise, because if you think of cannabis, if you think of even alcohol prohibition, anytime that you restrict something, there's going to become a black market. And the black market isn't regulated by anybody. People can just kind of produce what they want and sell it and say this is what it is. And there's a lot of danger and risk that comes with that. Whereas when you have a legal market, you have such a system in place to make sure that what hits the store shelves is tested, it's safe, and there is minimal risk. So it's not surprising to me at all that we're seeing these instances in the illegal jurisdictions.
That's a good point. Especially with standardization, that's what that's what you can expect. I mean, the legacy market still has a hold. It's grip, never going to go away just because the cannabis is really good and potentially really good. I don't know. Maybe it's really good. Shit. And but for the most part, yeah, that's a good point you raised.
Yeah.
Again, that's a positive note.
Yeah, it is
something that's positive.
And
let me ask. I gotta ask you a question. So I was just reading some articles about the WHO. Do you think the WHO really fucked up? Like, do you think they failed us in this COVID thing? Do you think that they didn't let us? I know it's totally like just off the wall here, but I was just reading some articles like the WHO basically said, don't worry about it. It's not transmittable. And back in the day, this isn't transmittable to humans, and let all these millions of people travel. Like, what's the story? I don't know. Anyway.
For me, as somebody who isn't a medical doctor and kind of was just looking at this on the news, I think initially it really gave me the impression like, oh, this is just like a trumped up flu. Like, it's absolutely nothing to worry about. So when I first started hearing about it, I wasn't really doing anything. I was like, it's just the news. They're hyping it up, whatever. And then like March hit, and then you were like, oh shit, this is not at all what we thought it was 3 weeks ago. Like, this is a whole different beast. And then like life changed instantly. And I think a lot of other people had that same impression, because when I was asking my friends, I was like, oh, like, are your classes canceled yet? Like, no, they're not gonna cancel classes over this. And people were like, oh, I'm gonna still go on my trips and stuff like that. So I think when that initial information was coming out, it really gave people a sense of like there really wasn't anything going on. And then now a few weeks later, we're like on total lockdown, and we're just like, what the F happened?
Yeah, I think they knew stuff. I think they just didn't I don't know. I think the WHO may have let us all down a little bit back when this all started. There is not a whole bunch of fun shit. Can we put up some of these fun slides? Okay, we got to see going to show you some fun stuff now. We got some slides here. We're going to show you some slides. Yo, Derek, can you pull up some of these? Yeah, so this is how people are going out. Like, come on, I love it. Look at this. There's one with this dude with the bag. Where's the bag over the head?
Wait, I want to comment real quick. As an ophthalmologist, I appreciate the cone, because it's not only helping to filter and make sure he's not inhaling, but it's providing a means of social distancing. So the likelihood of contracting it into his eyes, which is a form of transmission. If you don't have goggles, wear a cone. That's one message.
Look at this guy. This guy's got a helmet. This guy took a water.
What is that?
That looks like a water container, like when you pour water.
Wow.
How does that not fog up? That's incredible.
It's people come up with the crazy shit. So there are some fun things that have come out of COVID. Like, there's a dude with a scuba. Where's the scuba? Watch this guy.
Oh,
Oh no, that guy's just gonna kill himself by suffocation.
Yeah.
There's this guy.
Or by how high his pants are. There's some strangulation happening in both areas.
This guy's got.
Nice.
He's wearing his scuba.
Wait,
Anyway, these are just funny. All right. What else? Do you got one last thing for us before we close this off?
Wait, I don't know if you can see this.
Yeah, the scuba dude.
You saw that one?
I love it. Oh, geez, people are awesome. Oh, people are crazy. What do you got for us? Oh, this got to cover the dreads. Oh, it's just awesome.
Wow.
Oh, at least we get some fun out of this thing.
I know there's so
All right.
many ones you see every day, man.
All right, what else? You got one last. Give us like your best thing that something like that's like not so horrible that we can end off this show.
It isn't horrible. It's more interesting than anything else. So
Okay.
it's working for Bochosa, a California-based company that specializes in infusions.
Yeah.
They've determined that like when you know like all of a sudden there's all these CBD infused drinks and stuff like that on the market, but they've determined that the ones that actually come in aluminum cans, that the liners are actually causing the drinks to lose potency.
Mm.
Which is very interesting. Like I never even thought of that. So their theory is that the actual cannabis material is like sticking to the liner. So when you pour the drink or you're drinking the drink, it's like coming out without the actual cannabis ingredient. So it's caused these companies to kind of go back to the drawing board on the technology.
Well, that's pretty cool. So then, like, I'm gonna collect all the cans for 5 cents and then just scrape the insides and make a whole ton of money. Yeah, leaching happens, I guess, like with all different things. I think we're finding that problem with cannabis waters and all that stuff. Anyway, so much to talk about, so much awesome shit.
Yeah.
Nick, I've had an amazing time with you. We got to do this again because there's
Yeah,
so
for
much more to talk about, and I'd love to hear what's happening in the U.S. market. And I'd love to hear more about what you're doing. And as time progresses, please keep me and keep us here at Cannabis Wiki apprised. Is there anybody you want to shout out to? Anything you want to tell people to do? Go look at. Go find yourself. He is a single dad. People.
If you are in the market and want to move to a warmer climate than Canada, I may know an opportunity for you.
Okay.
Yeah, I mean, you can follow me online. It's a small account, but I do a lot of my cannabis stuff at Florida Bud Doc. It's on Instagram. A lot of my, I'm also on Facebook. I have a Facebook group that, shit, I don't even know the name of it. It's let me pull it up real quick. It is Medical Cannabis Applied Research Society. So again, it's Medical Cannabis Applied Research Society. Again, it's just a small group where I post not only videos but new research. I wanted to make a group because I'm sick of all these bullshit opinionated asshole people, and I was like, you need a place where you have somebody that vets out the research and then says, hey, look, this is a good study. Let's pay attention to it. This sucks. Throw it away. You get so many of these people that are these armchair experts now that think they can Google something they know what they're talking about. So just some things there. And no, I hope we do this often. This is awesome.
I'd love to have you on again. That would be awesome. Don't forget to check out Cannabis Wiki, cannabis.wiki. Check us out on the net. Check us out on Instagram. Check us out on the socials. You can see me at Dr. Ira Price. I don't even know. I think that's my Instagram. That's so funny. Yeah, I'm pretty sure it is. It's Yeah, that's it. You got it. Dr. Ira Price. And you can also check out Synergy Health Services. No longer need a referral. We're trying to minimize the amount of barriers there are to access, even in this world right now with COVID. It's added so much more to it. So now you just call us up and we'll get you in. We'll get you seen and I'll vet you personally and decide. But other than that, check out anything else we need to.
I'll say one thing too is for everybody listening. I know when I see a quality physician taking care of their patients, especially in the cannabis space. And Dr. Ira is that. He is that. And so you can go to one of these doc in a box places and get, whatever you need. But if you really want to take control of your health, with cannabis medicine, use it appropriately, figure out how to use it the right way, this is the man. And, it's been such an honor and a pleasure, privilege to meet you and to become friends and to be in this industry with you. So just for the people listening, if you want the good stuff, this is where it's at. We call that the good. This is the good right here.
Oh, thanks. I appreciate that, brother. Super.
Yeah, for sure.
Thank you. All right, everybody. I think we're done. I think we got this one down and we're wrapped up. Thanks for listening to the Higher Estate. And don't forget, we're probably going to start, I don't know when we figure it out, we're going to Higher Estate Morning Edition. We'll do an hour every morning for you. Peace.